Welcome to our video on chronic leukemias. Let's get started. Here is a list of topics we'll be discussing. This includes chronic lymphocytic leukemia, also known as small lymphocytic lymphoma, hairy cell leukemia, and chronic myelogenous leukemia. So let's start with CLL. With regards to this topic, we'll be discussing the general features, clinical presentation, diagnosis, and management. Let's begin with some general features. CLL or SLL is the most common leukemia in adults. It's common in people that are 60 years of age or older, and it's a mature B-cell neoplasm. It's mostly asymptomatic and slowly progressive. However, it might present with fatigue due to anemia, increased bleeding tendency due to thrombocytopenia, and hepatosplenomegaly due to malignant infiltration. Interestingly, CLL can cause autoimmune hemolytic anemia by producing either IgG or IgM antibodies directed against antigens on the red blood cells. Therefore, the patients with CLL might have IgG-mediated or IgM-mediated autoimmune hemolytic anemia. Richter transformation is the process when CLL is transformed into malignant lymphoma, most commonly diffuse large B-cell lymphoma, or DLBCL. A CBC may show lymphocytosis, in which case we call the disease leukemia due to the presence of malignant cells in the blood. However, sometimes there might be no lymphocytosis with malignant cells sequestered mostly in the lymph nodes. In this case, we call the disease small lymphocytic lymphoma, or SLL. A blood smear of a patient with CLL will show the smudge cells that are malignant lymphocytes damaged during the preparation of a slide. A bone marrow aspiration can definitively diagnose CLL by revealing malignant lymphocytes occupying greater than 20% of the bone marrow space. Flow cytometry of the malignant cells will show that they are CD20 positive, CD23 positive, and CD5 positive. Finally, if we want to diagnose autoimmune hemolytic anemia in a patient with CLL, we need to perform a Coombs test to look for the antibodies against red blood cell antigens. Here we see a blood smear image showing the smudge cells. Again, these are malignant lymphocytes damaged during preparation of a slide. The management of CLL or SLL is active observation in asymptomatic patients. In contrast, chemotherapy or radiotherapy should be initiated in symptomatic patients or in those with late-stage disease. Since there is no single guideline-approved first-line chemotherapeutic agent used for CLL, discussion of the different regimens is beyond the scope of Step 2. All right, let's try a question. A 65-year-old man comes to the physician reporting fatigue for the last 6 months. The physical exam reveals hepatosplenomegaly and diffuse petechiae on his skin. Laboratory findings are significant for leukocytosis, thrombocytopenia, anemia, LDH levels of 400, total bilirubin levels of 5, with direct bilirubin of 2 and low haptoglobin. Peripheral blood smear shows mature lymphocytes that are positive for CD20, CD23, and CD5. Which diagnostic test should be performed to identify the cause of this patient's anemia? All right, this patient presents with fatigue, most likely due to anemia. He also has diffuse petechiae, likely due to thrombocytopenia. The patient also has hepatosplenomegaly, and his peripheral blood smear shows mature lymphocytes positive for CD20, CD23, and CD5. Considering that he also has a leukocytosis, this presentation is classic for CLL. Patients with CLL develop anemia mostly due to IgG or IgM-mediated hemolysis. Hemolysis is further supported by LDH levels of 400, total bilirubin levels of 5, and low haptoglobin levels. Since autoimmune hemolytic anemia is antibody-mediated, we need to perform a Coombs test to look for either IgG or IgM antibodies causing this patient's anemia. All right, now let's move on to discuss hairy cell leukemia. Again, with regards to this topic, we'll be discussing the general features, clinical presentation, diagnosis, and management, beginning with general features. Hairy cell leukemia is common in adult males, and it's a mature B-cell neoplasm. Patients with hairy cell leukemia commonly have splenomegaly due to malignant infiltration. Additionally, hairy cells cause bone marrow fibrosis, interfering with erythropoiesis, thrombopoiesis, and leukopoiesis. Therefore, patients can present with pancytopenia. Finally, peripheral lymphadenopathy is uncommon. Okay, moving on to diagnosis. A peripheral blood smear in a patient with hairy cell leukemia will show hairy cells, and these are cells with filamentous hairy-like projections. A bone marrow aspiration will result in a dry tap due to hairy cell-induced marrow fibrosis. Malignant cells are positive for tartrate-resistant acid phosphatase, or TRAP. However, flow cytometry has almost completely replaced TRAP staining. Finally, we can potentially check for BRAF mutations in hairy cell as well. Here we see a blood smear image showing the characteristic hairy cells. Again, hairy cells are malignant B cells with filamentous hair-like projections. Here's a bone marrow biopsy image showing marrow fibrosis. And take a close look at these collagen fibers occupying most of the marrow space. Hairy cell leukemia is treated with purine analogs, either cladribine or pentostatin. Cladribine works by inhibition of DNA polymerase and ribonucleotide reductase. It also causes DNA strands to break. Pentostatin, on the other hand, works by inhibition of adenosine deaminase. Most notable side effects of both of these drugs is severe myelosuppression due to their effect on rapidly dividing cells. All right, let's try another question. A 52-year-old man comes to the physician due to recurrent nosebleeds for the last 7 months. He states that his nosebleeds occur either spontaneously or after minor trauma. He has also noticed significant fatigue recently. He can no longer jog in the mornings. The physical exam reveals massive splenomegaly. His laboratory findings are significant for leukopenia, thrombocytopenia, and anemia. A peripheral blood smear reveals tartrate-resistant acid phosphatase-positive lymphocytes with filamentous hair-like projections. The bone marrow biopsy is planned in order to obtain a definitive diagnosis. What will most likely be found on this patient's bone marrow biopsy? All right, this patient has nosebleeds, likely due to thrombocytopenia. His fatigue can be explained by anemia. He has massive splenomegaly, and his peripheral blood smear reveals TRAP-positive lymphocytes with filamentous hair-like projections. This description is most consistent with a diagnosis of hairy cell leukemia. And recall that hairy cells cause the bone marrow to undergo fibrosis, which in turn results in pancytopenia seen in this patient. Therefore, the bone marrow biopsy will most likely reveal marrow fibrosis. Okay, now let's move on to our last topic, chronic myelogenous leukemia, or CML. With regards to this topic, we'll again be discussing general features, clinical presentation, diagnosis, and management. So let's begin with general features. CML has a peak incidence in people from 45 to 85 years of age. The median age of onset is 65 years. CML is a neoplasm of granulocytes, mostly that of neutrophils and its precursors. A hallmark chromosomal abnormality associated with CML is the Philadelphia chromosome. This is created by a 922 translocation, which creates the BCR-ABL fusion gene, resulting in defective tyrosine kinase. Tyrosine kinase becomes overactive and stimulates uncontrolled cell division. Let's talk about the clinical presentation. CML can present with fatigue due to anemia. Hepatosplenomegaly and generalized lymphadenopathy are caused by malignant infiltration of the reticuloendothelial system. Finally, CML can undergo an acceleration phase marked by accelerated cell proliferation, and it can finally go into the blast crisis. And this is when CML is transformed to acute myelogenous or acute lymphoblastic leukemia. A peripheral blood smear in a patient with CML will show mature and maturing granulocytes, mostly promyelocytes, myelocytes, metamyelocytes, and neutrophils. A bone marrow biopsy usually shows malignant cells occupying greater than 20% of the marrow space. And we can also perform BCR-ABL mutation testing to aid in the diagnosis. This is a peripheral blood smear image of a patient with CML. And notice the granulocytes at different stages of development. The management of CML includes BCR-ABL tyrosine kinase inhibitors such as imatinib, dasatinib, and nilotinib. Side effects of these medications include myelosuppression, increased liver function tests, fluid retention and edema, as well as myalgias. Here is a nice table which summarizes the information we've covered about chronic leukemias. Feel free to pause the video and review this table. All right, let's wrap up with a final question. A 61-year-old man comes to the physician reporting an unintentional weight loss of 20 kilograms over the last 2 months. He also has severe night sweats, dyspnea with physical exertion, and fatigue. His vital signs include a temperature of 37.5 degrees Celsius, a blood pressure of 135 over 85 millimeters of mercury, a heart rate of 88 beats per minute, and a respiratory rate of 15 breaths per minute. The physical exam reveals hepatosplenomegaly and generalized non-tender lymphadenopathy. His laboratory findings are significant for a white blood cell count of 60,000, a platelet count of 500,000, and a hemoglobin of 8. A peripheral blood smear shows granulocytes in different stages of maturation. Granulocytes test positive for a 922 translocation. Which of the following is the best treatment option for this patient's condition? A. Imatinib, B. Pentostatin, C. Cladribine, or D. Radiation therapy. All right, this patient is presenting with B symptoms, namely unintentional weight loss and night sweats. He has hepatosplenomegaly and generalized non-tender lymphadenopathy. Additionally, he has a leukocytosis, thrombocytosis, and anemia. Anemia explains his dyspnea on exertion as well as fatigue. A peripheral blood smear shows granulocytes in different stages of maturation that are positive for a 922 translocation. All of these findings are consistent with the diagnosis of CML. A 922 translocation in CML creates an abnormal BCR-ABL fusion gene that codes for defective tyrosine kinase. Therefore, the treatment of CML focuses on inhibiting this tyrosine kinase by medications like imatinib, dasatinib, or nilotinib. So the correct answer is option A, imatinib. Recall from this slide that the BCR-ABL tyrosine kinase can be inhibited with drugs like imatinib. Let's discuss why the other options are incorrect. Option B, pentostatin, and option C, cladribine, are incorrect because these are used in the management of hairy cell leukemia, not CML. Option D, radiation therapy, is also incorrect because this has not been shown to be as effective as imatinib in the management of CML. So again, the correct answer is option A, imatinib. And that concludes our lecture on chronic leukemias.